to the Health and Social Care Select Committee and welcome particularly to our first panel. We're going to, within this panel, be talking about drugs and the criminal justice system, so thank you all for coming. For those following from outside the room, could I ask you to introduce yourself and who you're representing today, starting with yourself, Jason Harwin.
Jason Harwin, I'm the Deputy Chief Constable of Lincolnshire. I've been moved there 7 days ago, so it's my day 7 in Lincolnshire. But I'm the National Police Chief's lead for drugs, which I've been doing since September last year.
Thank you.
My name is Wojciech Spit. I'm a Detective Sergeant and I work in the Policing Strategy Unit in Thames Valley Police. I've been part of the team that's designed and implemented a drugs diversion scheme in one of our local areas.
Thank you.
Hi, I'm Stephanie Khalili. I'm a Policy Officer for the Durham Police and Crime Commissioner and I'm here today representing Ron Hogg, the Police and Crime Commissioner for Durham.
Thank you.
Hello, my name is Hardy Odinza. I'm the Police and Crime Commissioner for Derbyshire and I'm the Association of Police and Crime Commissioners National Lead on Alcohol and Drugs.
Well, thank you very much. And Ben is going to open the questioning this afternoon.
Yes, a couple of general questions to start with on the difference between a kind of criminal justice and a public health approach, really. And please, if I address my questions to particular members of the panel, don't feel that you shouldn't contribute. Stephanie, I wanted to begin with you because your Commissioner presented this committee with some very stark evidence in which he basically says the government should seek a more evidence-based approach. And what did he mean by that, or what exactly do you mean by that?
Right, so in terms of if you were to take an actual public health approach to drugs and drug policy, what he means by that is a more evidence-based approach. So actually at the minute, obviously, that policy is currently under the Home Office. So what he would suggest is actually that ought to be shifted to the Department of Health, whereby we're looking at principles which are evidence-based and informed so that we can actually bring in practice in that way. In relation to that, what he would propose is then obviously the decriminalisation of drug possession, but apart from that, what we're talking about, if you're talking about public health approach, which is evidence-based, actually scaling up of prevention, harm reduction and treatment in order to support the vulnerable people in our communities.
I mean, he quoted some very stark statistics from the United Nations Office on Drugs and Crime, that 9 in 10 people who use drugs do not suffer from drug use disorders. What exactly does that mean?
So this is the distinction between problematic drug users and people who take drugs recreationally. So when you're talking about a current approach, which is a whole face value approach, we're actually having a criminal approach towards people who actually aren't committing another offence apart from currently their drug possession. Whereas what he implies are actually why focus on our efforts on everyone, which is a quite costly operation, when actually you can deal with people in a different way if our policy was currently different.
So basically 9 out of 10 people who take drugs at the moment are not committing crimes themselves or doing themselves any, whatever this thing is, have a disorder as a result. Mm-hmm. But we're focusing on them when we should be focusing on the 1% who are causing the problem.
Exactly, yeah. And that is the ones who cause most demand to...
The 10%, yeah.
10%, yeah. Who cause most demand on our police forces, on emergency services, the criminal justice system, health and social care services, yeah.
And what difference would it make moving this policy to the Department of Health?
It would shift the priority, so from a criminal, rather than a criminal approach, into a health approach. So actually, you're talking about intervening in someone's lives to actually address the underlying cause of why they're taking the drugs in the first place. And I think such a shift would actually reduce a bit of the stigma associated with the criminalisation of it as it currently stands. That would enable people to actually come across, not fear the law and the police, and so that they can come forward and actually address their health issues.
Deputy Chief Constable Harwin, from a police officer's perspective, is that an approach or a view that you would share with?
I think it's firstly fair to say yes. That there's 10% that obviously we have more contact with in terms of whether it be committing criminal offences or obviously in terms of vulnerability and ultimately the consequences of drugs. I think what we're going to be very clear is ultimately the other 90% at the minute with how the law is set is obviously commit criminal offences. The fact is they're not coming in contact with the police service means actually there's demand there that we don't actually understand actually how we respond to it. The important piece for certainly from the MPCC side is we're here to reduce harm. So it's not just about enforcement, we're here to reduce harm. And the evidence base shows at the moment there is some other ways we could approach this through a public health response that actually would have a greater impact longer term than probably some of the work that we're doing at the moment. importantly for the police service, and again you probably hear some this afternoon, is there's activities taking place throughout the country where clearly it's about an appropriate response to the needs of an individual, understanding the needs of an individual, where ultimately yes they commit a criminal offence, but what we're trying to do is make sure they're no longer vulnerable, and just as importantly make sure they don't re-offend after that first offence. And again there's evidence showing that at the minute some of that work is working, and again from the MPCC we're clearly keen, as we have done, to share that practice throughout the country to see how do we make that more effective and make sure we get some clarity and consistency in the role of the police in that role as well.
I mean, in your written evidence, you say that criminal justice approach will not solve problematic drug use, and criminalisation of drug users often creates a cycle of reoffending and does nothing to address the underlying and contributing social issues. So are you saying that in your practice you're working around that by doing other things instead?
No, what we're saying is firstly a crime has been committed, so we're not saying that it's not a crime being committed. What we're saying is what's the best outcome for that individual to stop them re-offending, but just as importantly, how do we protect the wider public? And when we say the wider public, potentially the individuals that are associated with that individual. So by way of example, looked after children, a significant amount of young people are going into care at the moment as a result of a family in crisis which is being driven through drug use. What we're trying to say here is by an effective evidence-based practice to manage their crisis and their vulnerability, we can reduce harm not just on those individuals but on the wider family and then for the wider community, where ultimately there is an organised crime element committed to this, where it's ultimately feeding that supply of illicit drugs. That's how we need to be a bit more effective.
And what's the National Police Chiefs Council's attitude to moving responsibility for this policy area from the Home Office to health? Well,
I think the thing is ultimately it's everybody's responsibility. It's not just one department, it's everybody's responsibility. The College of Policing, working with the Public Health England, have recently published some guidance in terms of public health response to crime and vulnerability. Importantly from our side, we recognise that whilst the police service has got an important role to play in this, we are not the solution. We are part of where we need to quite rightly target those that are profiting and ultimately exploiting people to commit crime, but ultimately we've got individuals here that are not just drug users but have got other social dependency that we need to address. The police service can't address that. Health and other providers can, and again hopefully there's some examples of that this afternoon.
Right. Mr Dinser, you had something I think you wanted to come in.
To add to that, I mean, policing has a role as long as we have the law as it is, but we cannot enforce our way out of this problem. So a health-led approach is the right one, in partnership with the criminal justice system as a whole. Police, courts, probation services, youth offending services. So it needs to be, and I welcome this committee's inquiry in this, a health-led approach is what's needed, and police and crime commissioners can play an important role in how that can be delivered at a local level in terms of strategic thinking and joining up different agencies.
When you say policing has a role, enforcement has a role as long as the law is as it is, it would seem to suggest that you think there are better things that you could be doing with the resources you have in this area.
I mean, that is a debate that goes on in terms of the 10% and the 90%. There are examples. The police do a very good job in terms of enforcing the law, but it's got to be proportionate. That, however, has not, in the last 40, 50 years, led to a reduction in demand, use and supply and criminality, despite the fact that people are locked up and more the police are working with vulnerable groups to help divert them through the schemes that are presented here, to get them into support and treatment and recovery and diversion. Despite all that, we still are not making impact. So we need to join up and collaborate more than we are now.
So the current policy hasn't worked, basically?
It can't work on its own. It needs to be joined up.
Do you want to come in?
Well, I was just going to say, irrespective of your views on how effective prohibition is, those people that the police do come in contact with, prohibition has failed. That deterrent effect hasn't worked. Otherwise, those people would not be in possession of the drugs. So for those people that we do come across with the drugs, we need an alternate policy or an alternate strategy to address their drug use, and the police aren't equipped we're not medical professionals, so we're not equipped to deal with that drug use.
Drawing perhaps on any international models that you might be aware of, I mean, how would you like to see drugs policy and the strategy change over the next 5 years? It's a question for all of you.
I suppose first it's got to be evidence-based. So, and again, it's got to be relevant for England and Wales for the MPCC, and obviously the wider piece, including Scotland within that as well for the Home Office. But the important bit here is it's not about one element. So lots of conversations about different elements of evidence-based wellbeing, drug consumption rooms, heroin-assisted treatment, but you can't do it in isolation. So the important bit for me is it's firstly about statutory responsibility in all organisations, that actually everybody's got a responsibility to address this issue across all government departments, but just as importantly about that needs assessment. So going back to the first part of the public health response is about understanding the needs of communities and then making sure the response to that need is in line with the evidence base that will work. Mm-hmm. This is not about a universal approach across the UK from what I see. This is about a targeted intervention that's evidence-based, where actually therefore the right partners are involved with the right evidence and right funding and resources to actually address the problem. At the minute, that's not the case.
If you're looking at in the next 5 years, strategically, we need to see how the criminal justice system works more joined up with the public health department at a local level and a national level. And the work that's been started by the drug working group, chaired by the Home Secretary, is an important point in terms of how the departments across government are more joined up in terms of education, awareness and diversion by public health and education, and then work on families. So if we're looking ahead to the next 5 years, I think the strategic join up at central government level between different departments, because it's not just a health and criminal justice issue, it's a social issue. And then at a local level, leadership that police and crime commissioners give in terms of joining up and maybe co-commissioning with public health departments services on the ground to provide treatment, diversion and recovery services which join up with the criminal justice system.
Would either of the other two of you like to add anything to that?
Yes, to echo both those comments, the police is a gateway. So the police is a gateway either to criminal justice outcomes, whether that is through the courts or those administered by the police, or to public health outcomes. And the evidence base, the evidence rather, is so important. All the current policies that are being trialled, we are attempting to see whether different public health outcomes or the criminal justice outcomes have greater or lesser impacts, for example, on reoffending, but also from the public health perspective on continued drug use.
Are there any foreign models that any other countries think do it better than we do?
Well, there's a number of countries, aren't there, where we decriminalise or involved in other interventions. I think the important bit is, whilst clearly we need to look at what they're doing, but the important bit is you relate that to here. So it's not about saying just because they're doing it here, it's going to work here. Again, it goes back into how's the whole system work. Bearing in mind, like I said at the start, a lot of the individuals we deal with here are in crisis, are very, very vulnerable, ultimately feel they've got no other choice but to get through the day by taking drugs. But it's not just about the taking drugs, it's the underlying issues of why they need to take drugs. Yeah. That's the piece around the public health becomes better, more informed, and therefore make sure there's the right outcomes for that individual as well.
Thank you.
Follow-up question.
I just wanted to understand a little bit more about the 90%. I understand the 10% that are causing the major problem, but the 90%, I've just sat on a committee looking at domestic abuse, and one of the things that came to light was that people who suffer from domestic abuse don't go to the police. They might contact the NHS before they'd ever speak to a police officer. And I just wondered if that 90%, one of the key factors around domestic abuse is substance misuse in the home, which causes problems in domestic abuse. And I just wondered, are we really sure that it just seems to me rather stark to say, well, it's just the 10%. It might be that 90%. There's all sorts of other stuff going on that is very harmful, that's just not registering because it's not being brought to the police's attention. So I just wondered if you could perhaps explain that a bit more to me. Is that correct? Or?
Interesting, in the drug diversion that we've had in Thames Valley Police, we've been referring people to the drugs service provider who wouldn't usually come into contact with this particular cohort of people. And they have been, so for example, we will stop people for cannabis and then they will further disclose use of other drugs. So there is certainly an aspect to that whilst they may not present with particularly being problematic for us or for society, there may be underlying issues that we're not capturing.
I think, just to take the analogy of domestic abuse, there has to be a robust assessment process, because some people's presentation about what, say, for substance misuse or domestic abuse may not be, on the face of it, very concerning. But if a proper risk assessments are in place, screening and assessments are done, and that's probably not police officers doing that, but experts who are equipped to do that better, then you can decide who you need to intervene with and who you don't. And I think that's something that probably is happening in policing in many ways. The law says that we do need to uphold the law, but when you then take action, it's proportionate based on, and police officers will tell you how they decide how much action to take and how much support and vulnerability referrals need to be made. So I think it's probably wrong to say 90% you can forget. So, the screening and assessment is really important because one of those may not present as having great difficulties, but if you dig deeper, there may be issues that need to be intervened with.
I know Jason wants to come in as well. I'll come to it.
Challenge back in terms of do we understand the other 90%? I think it's fair to say in terms of understanding the demand on drugs and on the criminal justice system, and then the wider bit around public health and obviously other society and communities, it's not really, we don't know, if we'll be honest. We know some of it, we don't know all of it. Importantly, some of the work we're doing in terms of serious violence at the moment to understand better how drugs is driving serious violence is starting to help us understand better the demands. And again, it's showing that actually the use of drugs, whether that be illicit or prescription and mixed both together with polyuse, is a bigger issue than we were seeing in terms of recorded crime. So clearly we need to
I know you
that.
wanted to make a follow-up point as well, didn't you?
Yeah, it was in relation to obviously drugs in the context of domestic abuse, but actually when they talk about the term adverse childhood experience and the fact that actually some of the people who take drugs actually have suffered some sort of trauma in their childhood life, and they take it as a way of coping or recovering. They're the 90%, I guess, which don't necessarily come into police contact unless they come under kind of the vulnerability aspect or as a victim, which actually require a different and more proportionate outcome rather than a traditional criminal justice sanction such as a caution or a charge. And essentially, so it's a different response.
I'm going to bring Andrew in for a point as well here.
I just want to pick up on the term recreational drugs use. It's a term I'm rather uncomfortable with. And I think, to be fair, I think the government have used it in their 2017 strategy, so you can blame the government for first using it. So I'm not having a go at any particular one. But I just wondered if, amongst any of you, it just has some rather worrying connotations. We've heard Diana talk about the 90%, the links to domestic abuse, the links to other criminal activity. Personally, I'm rather uneasy with the use of that phrase. I mean, Jason, would you rather it was a phrase that wasn't used in...
Well, firstly, from my side, you'll not hear the National Police Chiefs Council talk about recreational use. You probably hear the contrary to it, that actually it's illegal. If it's illicit drugs, it's illegal. That obviously fuels crime. And accepting about the vulnerability of individual use, but the wider piece is that we recognise that actually, even if the person is not in service, and cocaine is a prime example, actually it's fueling organised crime, which again we can show from obviously production all the way through to transportation and delivery in the UK and throughout the UK involves exploitation, whether that be of young people or very vulnerable people. The point around is we will not use the word recreational because actually it's illegal.
Excellent, thank you.
I suppose it's important we don't forget the murders that will be carried out overseas as part of the wider network. So to imply that it's a consequence-free choice, I think, would be worrying.
I think you're quite right in terms of the use of the term recreational is probably inappropriate. But if you go underneath that, the problem we have is a social problem in terms of how we tackle drug substance misuse and who actually does that. I mean, the Home Secretary has charged to middle class white people who may be categorised as recreational users to stop using substance misuse because that will reduce supply. The question is, how do you stop social behaviour in terms of people taking substances, whether it's alcohol, smoking, and what approach is the right one to actually sort of tackle that problem in terms of education, awareness, risk, and giving informed choices for people to make? Because we know that despite all the efforts of the criminal justice agencies, the behaviour has not stopped. So whether it's people who misuse it and don't actually come in front of the law, or it's people who are misusing it because they've got other issues, mental health, accommodation, employment issues, and they come into this public services, including the police. There's a distinction between those two, but there's a deeper question is, how do we look at the social activity of individuals who take choices about taking alcohol, drugs, smoking, or whatever.
Thank you. That's great. We're going to come on now to Paul.
Yeah, quite quickly moved on in our discussion to the need for a biopsychosocial approach to this. But can I just take you back to policing and ask whether the police actually have enough powers to be able to carry out their duties within the law with regards to drugs?
I suppose the question back is what are we trying to achieve? So in terms of enforcement, there's lots of powers where we can stop and search people, we can recover drugs, we can obviously put them in through a process of referral, particularly under arrest. What we can't do at the moment, as you will see, number of arrests for drug possession is reducing. Some of that is because the legislation has changed, where actually we've got to show a necessity to arrest. And also the fact is we've got other outcomes we can deal with that individual without putting through a custody suite. And obviously the association is run a custody suite. What's not happened is, in terms of a person that attends on a voluntary attendance, it would be with consent ultimately if they are willing to do a drugs test. There's no power of the police service got to do a drug test. Also, if you look at drug testing on arrest, that doesn't involve serious violence. So we have a serious violence issue throughout the UK at the moment. If you look at the use of drug testing on arrest, within the legislation, it doesn't involve violence. An inspector can authorise if it's in relation to violence, but it's saying as part of the authorities, it's not actually set as authority for violent-related offences. The important piece in terms of the rest of the legislation is clearly we get into a position where, and I'll use the example at the minute with prescribed cannabis, where clearly people are now quite rightly having prescriptions to access medical use for cannabis. But at the moment, because they cannot access cannabis, the police service still ultimately get involved in the middle where they're in possession of cannabis because actually they can't get it legally because it's not available, and therefore they find the position that because of their medical condition, they feel they need to source cannabis, and therefore they source it by other means, which is illegal. Straight away the police service gets in a position where that is illegal, but clearly in terms of the moral position, we've got an individual there that has been prescribed, medically needs a requirement to have a cannabis substitute realistically for their medical condition, but because they can't access that substance, straight away then obviously the police service get involved. And that is a real dilemma for police service, where ultimately we are trying to enforce the law, but ultimately we're trying to enforce the law to minimise harm longer term. So it's not just about the short-term piece, as the Police and Crime Commissioner touched on there. We can arrest lots of people, as we do every day. We can cover lots of drugs. But the reality, whilst the demand is there and individuals need drugs, straight away the supply will continue to come.
Can I just check with what you're saying about being able to do compulsory, more powers to test more people? Is that likely to identify more of the 90% for whom it is less problematic, and therefore be not a particularly good use of powers, or do you think it would potentially identify more of the 10% where it is problematic?
I think what it'll do is give a bigger picture than we've got at the moment, because we're not testing those that's coming through the voluntary attendance. Now, again, some of them will be already in service. I use an example of drug driving. Drug driving, as you'll know, is getting a greater profile in the country. Straight away, you're seeing, and again, I use an example from my previous force, over a 6-month period, we arrested as many people for drug driving as we did drink driving. The issue there is what happens to those individuals being caught for drug driving. Yes, may get banned, all the issues around, but what about referral into the system? How do we deal with still the underlying issue that they've got a drug need and therefore prevent potentially committing other offences, not just in terms of the drug driving?
So, more biopsychosocial options, yes, but perhaps some more powers for the police to be able to act on the front line to identify as well.
And that's really important. The issue for the police service is that we are likely to increase demand, which is good because we're trying to address the underlying issue, but we need to have the provision behind it to be able to deal with that demand and therefore make sure, again, it's a whole system approach of what we do when the referral comes in.
Okay, would you like to see that?
That's the crux of it. You can have more powers, but at the end of the day, once you've got those, we still come to the same point about vulnerability and actually what's the best action to stop that person reoffending again, and therefore demand and sort of treatment services that can take
so not more powers to lock people up, but perhaps more powers to be able to identify where there are situations where there may well be great vulnerability that drugs are involved.
And I think that's the area that your committee is really, I'm really pleased that you're looking at, because the health-led approach has got to be the way we go.
Health and wellbeing boards have a statutory responsibility to identify needs and commission services. At the minute, the police service is not a statutory partner in health and wellbeing boards. You'll find throughout the country the police are represented through relationships with both the local authorities, which is their responsibility, with the wider health provision. But actually we need to be around that table as a statutory responsibility to influence the needs assessment to make sure then we're protecting all people. And the minute that's not in law, it's not there.
I found a very good example in my own local authority area where I met with public health commissioners who are recommissioning a new substance misuse service and hadn't had in-depth conversations with the Police and Crime Commissioner.
Yeah.
And so I'm making sure that they're coming together because clearly there's a mutual interest.
One of the biggest challenges in the drugs diversion was to find the funding for the additional people that we were referring. And actually the local authority was worked really hard to alter the KPIs that had been set in the contract for the drug service provider to enable them to deal with the additional demand that we were sending their way. But potentially, as we are a gateway, so if that gateway becomes bigger, then the ability of the services who we are referring to need more resources.
Yeah. And does that mean the police and local authorities working together on? Does it necessitates police and local authorities working together in the commissioning of services? Yeah. Can I just ask you, does the UK system of drug classification help in any of this, or does it hinder?
Does it stop us doing what we need to do? No, it doesn't stop us doing what we need to do. Does it cause some confusion at times? It does. In terms of testing, do we know what we're actually dealing with? Testing is an issue for police in the UK, it is. And again, in terms of provision to be able to test outside the criminal justice process, again, that's a conversation we're having within the MPCC with me about our capability to do that, not just in terms of policing, but again, looking at other providers for the prisons, again, working with the prisons about how we work together to identify potential vulnerability in terms of substance, because the substance just changes, you will know very well, but also in terms of our response to how do we respond to that differently as well.
We've recently had a Psychoactive Substances Act. What have the effects of that been?
Well, again, the evidence, again, it was evaluated, shown that actually in terms of premises being openly selling such things obviously has stopped. The issue is the online piece now where people are obviously accessing things by other means, and the online is a massive challenge for police service, not just in terms of drugs, but how we deal with the online challenge of criminality, in particular and organised crime as well.
I think the other thing is that the supply of psychoactive substances has been more used by homeless, complex mental health needs people who find it cheaper than other areas because of supplies, and that has made homeless people the focus of the antisocial behaviour you see in towns and cities. So interventions particular to that group are required as a result of its reduced usage through that act in one area, but it's actually highlighted vulnerable communities, groups, homeless people in particular, all up and down, where we see zombified individuals taking that and being supplied with that more easily, and there's a need to respond to that interventions to help those individuals.
So these people are getting better access to psychoactive substances, or
it's easier because I think psychoactive substances are more easily available because they are chemical, they are not herbal cannabis, it's synthetic cannabinoids, so their production and makeup can be done differently. It doesn't require massive, there can be chemicals that can be put together easily on site and made easily available. And they go into prisons in the same way, as we know, because they can be sprayed on a piece of paper, for example, and sent into prison, which is less easy detectable. So it's accessible and cheaper, and those people who are destitute, homeless, and have less resources are accessing them, but then they are causing problems in our towns and centres, and there's intervention required at that level.
Thank you.
Rosie.
Initially to Assistant Chief Constable, the first part, and then the second part for all of you. So I suppose the first part of the question is, how do police currently contribute to the harm reduction in relation to drugs? And then for the panel overall, what your thoughts are about the current legal and practical situation with drug consumption in the United Kingdom.
Okay, so firstly, what's our contribution? Again, I touched on it earlier on about Health and Wellbeing Board. So we're throughout the for England particularly, we have got representation at Health and Wellbeing Board that's helping with the conversation about understanding a joint needs assessment, but all importantly about commissioning of service. but it's very much postcode lottery, if we'd be very honest, because the statutory responsibility is not there for us to do that. The second bit is that we recognise, and again you've got examples here where diversionary schemes, where clearly we want to make sure we are referring people into treatment as soon as we possibly can in our contact with those individuals. So whether that be a case of the homelessness issue where we're coming across individuals on the streets that may not be taking drugs at that time, but clearly have got some vulnerability that we need to get into pathways and making sure again they get the relevant services. And again, there's examples throughout the UK taking account of the issues with spice, which again has been well reported, is actually making sure it's a joint response with the drug services, with local authority responsibility to make sure we've got joint responses to those issues in communities. So we're in part of a multi-agency team realistically. The wider bit is we have legislation, as touched on earlier on, where we need to, and we've got a statutory responsibility to refer people into services at certain points within the criminal justice process as well. The issue for me goes back to now in terms of the recent guidance, which is evidence-based through the College of Policing about that needs assessment piece. Again, understanding this is not just about drugs need, it's about the wider needs of that individual, hence that family and the wider community. By making sure we are influencing that conversation about what we know, what the local authority know, what treatment services know, and importantly what the third sector know about individuals, involving that individual, straight away we'll have a better response because actually we've got a more informed position. In terms of the issues regarding drug consumption rooms, heroin-assisted treatment is evidence-based. Again, Mr Williams will know there's some activity taking place in the Cleveland, Teesside area at the minute that is evidence-based, that will have a massive impact in supporting individuals that's in crisis and will have a greater impact in terms of protecting communities and stopping serious and organised crime. The issue again goes around funding. So at the minute that's funded through a joint commissioning, ultimately through the Police and Crime Commission, the local authority, public health. The piece for us is it can't be postcode lottery again. If you're an individual that's got a need for whether it be an opiate-based substance, you're entrenched in treatment that's not working, we need to stop that treatment and give into evidence-based treatment that does work. The issue again is, depending where the funding sits to that at the minute, that's how if you get the treatment or not. That can't be acceptable in today's society. Drug consumption rooms is a really interesting debate. Lots of issues in terms of understanding the difference between heroin-assisted treatment and drug consumption rooms. Drug consumption rooms have evidence-based that they do work, but again, it's got to be part of a wider whole systems approach to actually public health response to it. And again, it's got to be done in terms of understanding what you're trying to achieve from a drug consumption room. And it's not just about allowing people to take illicit drugs. It's about safety. It's about stopping drugs overdose. And importantly, it's about the wraparound of other services to try and ultimately take that person away from illicit drugs, to manage the need for drugs, and therefore put them into other services as well. The issue that I'll always say is it's not a universal response. Drug consumption shouldn't be seen as a universal response across England. What it should be considered is an appropriate response as part of a wider public health strategy for the issues that particular area faces, which again links into the issues around public consultation and the wider piece about where actually some communities are suffering, where drugs are being consumed in streets. And I'll always argue drug consumption rooms exist without the title in some people's houses, realistically. And people are dying there, so...
How do you struggle with referring people on? And it's all right talking about partnership if those resources aren't there and you've got public opinion to get over in the first place, but then having that row, if you don't have the resources, how do you deal with that?
Well, the first bit is influencing the commissioning. So making sure, again, where we clearly see a need and understanding the need, and that goes back to the point, do we understand the demand that drugs is driving? Straight away is we're making sure that through the commissioning and being around the table, where we should be around the table, statutory with health and well-being agenda, is actually we're in for that conversation. The point here is this is not just about, a lot of people will say, this is just to stop police demand. No, it's not. It's to stop vulnerability on that individual, an individual that has association potentially impact on their family, where their young people could be taken into care, and obviously associated issues when people are taken into care, but just as importantly, because that person feels the need and has no other choice but to take illicit drugs, it's fueling serious and organised crime that we show is linked to violence, that's linked to 60% of homicides in the UK, and ultimately is linked to nearly 45% of any house broken into is linked to drug dependency and everything else. So the piece for me goes back to, if we don't stop the demand and the need for drugs and deal with that by a different way, the supply will continue to come. And despite lots of effort, lots of drugs being recovered through all the different law enforcement services. So it is that conversation that we're hopefully having on behalf of the MPCC with other partners about how do we do this a little bit differently. And that's why you're seeing the diversionary scheme about reducing demand, appropriate pathways in, and therefore starting to cut off the need.
The rest of the panel?
Yeah. So in relation to the question about what the role of policing is in harm reduction, I think it's important to remember one of the core missions of the police service is to actually protect human life. And therefore many other countries around the world which have kind of focused on a harm reduction policing kind of approach have seen a lot of benefits in terms of public health, but also public safety as well. And I guess such initiatives include things like needle exchange and naloxone use amongst police forces, heroin-assisted treatment, as our colleagues have already spoken about. And they're just a few examples where actually the police can actually tap into these communities which struggle to engage with mainstream service, and that's our way, as my colleague said, about kind of gatekeeping and actually getting them into harm reduction services.
Yes, I think harm reduction, you've got two very good examples here. Diversion schemes can help reduce harm because you get people into treatment and recovery as opposed to the criminal justice route. We've got others, we've got Avon and Somerset, we've got North Wales just going to implement something similar using Checkpoint as their sort of experience base. The problem from a police and crime commissioner strategic perspective is that it's ad hoc. Some places it's happening, some places it's not. And we need a mechanism by which we understand the good practice and the evidence and actually have a framework which enables it to be done consistently right across the country. So one of the things I wanted to take to the drug working group is how our report diversion schemes, we look at the best examples and say, well, this is a model that should be actually delivered in partnership with the police, with other criminal justice areas and the Public Health England and Public Health Department. So that's one approach. The second is in terms of treatment. If you are convicted, treatment orders, and how do local public health departments commission those services? Now the reality is that's been going down and down in terms of funding, and therefore the number of people put on drug rehabilitation requirements have been going down, and there's a risk that that could go further if the ring fence for public health funding is removed in May 2020, and that's the debate that's going on at the moment, whether that's wise and right to do, because we need to actually make sure that the funding we have for health, but not just for health, but how it joins up with the criminal justice system to actually improve harm reduction and alternative intervention, which is treatment and recovery. So that's what we need to look at to build on all the good examples we've already got.
From a statutory perspective, we found that youth offending teams are very well set up to intervene because they offer a very holistic service from all sorts of areas, from education to health to housing to social care. That system is not in place for adults. And so ultimately, whilst we refer people to a public health outcome for drug support or diversion or education, the other underlying aspects may not necessarily be available, for example, housing or other mental health issues. So there could be benefit in bringing a more holistic approach that is made statutory for care of the people that we refer. And the second aspect is, as has been highlighted, is that whilst we make sure that we work within the law, all of these schemes are very different. And we work closely with the Ministry of Justice in order to be able to have the dispensation to work and try different approaches, but it is a lottery as to which one works in what area.
A lot of questions to get through, so we need to probably be much shorter questions. Diana, do you have a very short follow-up, and then we're coming on to Andrew?
In terms of harm reduction, is there a particular issue with spice? It was mentioned by one of the panel, and I just know that in the east of England, Lincoln and Hull, there are people lying on the floor in city centres in a way that you don't normally see with people taking drugs, and I just wonder if there's a particular harm reduction issue there.
Yeah. So obviously I live in Lincoln now. So I've done the walkthrough. Again, there's been some initiatives done through multi-agencies of what works to, again, not just deal with the individual drug need, but also the wider issue while that person's not living in accommodation, not in work, etc. I think it's fair to say the PCC touched on it already in terms of spice is very cheap. So the reality is it's ultimately used as a means to ultimately get through a day. It is. I've spoken to users. We've hosted a number of workshops. There was a national conference at the end of last year with the police services and public health says what is our response to it. The issue is there's no necessarily treatment for spice. There's not. It's about why people are taking spice, an underlying issue. So it is one that continues to create an issue, particularly where it's very visible in the town and city centres. but it is one that actually there's some evidence base of how it's effectively being done, which is around peer review work, which again is evidence based through the universities that we've been working with to make sure we address not necessarily the drug taking base, but the underlying issue why they're actually on the streets and why they need to take drugs as well.
Get through, so I'm going to come on now to Andrew.
Thank you. Could you tell me what role the police have in trying to prevent drug use in the first place, or is that not really your role?
No, it is. Again, the police service, as my colleague said, we're here to prevent crime, not just respond to it. So again, you'll be aware of we do some joint working with local education, and particularly around young people, and about how we educate young people in schools. Our capacity of that...
What do you find effective? I was having a conversation at lunch with some young people, and I mean, you know, older people, if you're my age, telling young people not to do things, not always terribly effective, is it?
So some of it's around...
What does work with young people?
Well, the first thing is, what do we mean by young? So we obviously have a number of mini police schemes now you should be aware of, where we do intervention in our most challenging communities, most deprived communities, and therefore we start working with young people about building trust and confidence, because that's the first part, particularly if they come from a family that have very little confidence or trust in the police service. But ultimately is around that influence. So again, it's not necessarily the police service. While we're rising on the law, we work with other providers, third-party providers, to say is understand the consequences individually. And that's around peer review. So getting other people that's been involved in taking the drugs, the impact it's had on their life, their family life, that's the way we see the greatest benefit. The challenge is we haven't got enough capacity in policing to do it in all areas where we actually would want to target it. It's very ad hoc, depending on the police capability of each force.
Has there been any evaluation of what is most effective in terms of prevention?
There has been. So again, some of the work that's been done in terms of the role of the police working within education, and ultimately in terms of working with the partners, there is some evidence base. I've not got it with me, so again, I'm very happy to submit that to you. If that's
true, what you think has been most effective in the prevention area, that would be helpful. Okay. So, Jason, just carrying on with you, if I may, in 2011, I think roughly there was a 60% conviction rate for drugs offences, and I see for 2018 we've gone down to not much over 35%. So that's a very big shift. What's been behind that? What's going on?
I think there's a number of issues. If we talk about the capacity of the police service to be proactive in target enforcement around serious and organised crime. There's been limited capability, and again, if you look at the amount of drugs recovered by the police service and other law enforcement services over the last 12 months, again, it continues to reduce. I think it's 2% down this last 12 months. The other part is that there's other schemes starting to be created where ultimately we're not necessarily looking to criminalise the individual, so we still record a crime, but what we're trying to do ultimately is making sure that that person vulnerability is addressed and therefore don't want to commit further offences. And again, some of the schemes that's been talked about here is making sure that actually we're not looking to send people to court unless we really need to. What we want to do is make sure we address their issue for committing crime and therefore prevent further offending in the future.
Okay, it's still a big shift, isn't it? And I mean, was this government directed? Was it the police on the ground just sort of sensing it was the right thing to do? I mean, I have these conversations with my own police force, and they tell me that, you know, sometimes these things are in fashion or out of fashion. It just sort of worries me a bit. I'm not quite sure how policy is being evolved in this area, but it's a very big shift, isn't it?
I think it's fair to say, in terms of policing priorities, that drugs, whilst it's a driver of crime, is not the only thing that we have to deal with. So when we deal with other prioritisation, so we deal with the new emerging crime around cybercrime, the wider issues around modern slavery, clearly quite rightly we need to understand and address those. So again, it comes around competing demands. I think the important bit here is, and certainly the work that I'm doing with the MPCC, is recognising drugs is a big driver of criminality, whether that be it still links into organised crime. So again, it's on the rate. Importantly, we now have a national strategy. The national review hopefully will influence that strategy to get it up to date. But importantly, from the police service, we recognise that we can't do this on their own, and that's why we are obviously asking for public health support around a public health response.
I want to move on now to the diversion schemes, which the police are starting to use, and we've got briefing on three of them from Durham. The overlay of the criminal justice system in order to get people into these schemes in the first place. Am I right in my understanding of that? Because we say to people, right, it's a criminal justice route, or if you comply, you can go down this route. Is that correct?
So,
we need to stick as well?
Yeah, so the important bit is, if people don't comply with the scheme, which is important because there's got to be some deterrent at the end of it if people not, because what we don't do is keep putting people to court or put through the process they don't, then clearly after a number of stages then ultimately then it goes through a criminal prosecution realistically.
Right, so when we talk about decriminalisation, we have to be quite careful in terms of what we're talking about, don't we? Because we need that bit of the criminal law to be there in order to drive, I think, the type of schemes that I think we're all broadly in favour of. Would that be correct understanding?
It would, and again, the important piece there, and again, this is where some of the schemes are slightly different, but using checkpoint as an example, the amount of time people are on that scheme initially to make sure they comply with the scheme, if they don't comply with the scheme, then obviously we can still report on summons and therefore they go through the court process. The important piece here is we recognise that you can only give people so many choices, opportunities. At some stage there has to be a line saying that's gone past that and therefore we take action.
So, as so often in this country, we seem to have three great initiatives. Are there evaluations? Do we have results? Do we know what works?
We do. So again, I know it's rare, but actually we have the checkpoint is evaluated, the Thames Valley piece has been evaluated, and the Bristol, Avon and Somerset and the West Midlands one has been evaluated as well. The important bit is where the college then comes in about how we disseminate that information, not just in terms of the National Police Use Council, but across the wider partnership, and again that's where the public health piece comes in.
So is the College of Policing working on that?
They're involved in the strategic boards that we chair in the minute in terms of drugs. The important piece here is again that as part of the policing, understanding and professionalising and what works, there's work streams there about reducing harm.
Okay, so where I'm sort of going to with this line of questioning is we've got these three initiatives. You tell me hopefully there's some positive evaluation. We know this is working. So when are we going to have this rolled out nationally? If we know it works, we know there's a good evidence base, presumably we're going to take the best elements of all three schemes and try and roll them in as a sort of national programme. What's the time scale on doing that? And what are the barriers in the way to doing that?
Shall we bring in...
Just to address that point that you're making, the evaluation which is most advanced is checkpoints. So there's evidence to show that there's a reduction in offending and reoffending as a result of the intervention, which is a deferred sentence of the court for 4 months. So there is evidence on short term, and now you're waiting for a year before you get longer term impact. So that is the most evaluated and progressed. That model, in my opinion, is something that can be used to sort of look at a model which we can have nationally, which can be versions of the different models.
So just my frustration, as always, in this committee quite often, is we have something that works in one area, but we are pretty hopeless as a country at establishing that evidence base and then rolling it out. So how are we going to do that?
Could I just finish? The challenge to police and crime commissioners was exactly what you just said from the drugs working group by the Home Secretary. If it can work in some areas, why can it work? Why can it not work all across the country? So that's the piece of work that Jason Harwin as the NPCC lead, myself as the APCC lead, have taken one paper to the drug working group, and the next paper will be to say how can we have a model which can be delivered across the country. Now the issue is going to come down to funding, because the funding source at the moment in Checkpoint, for example, is the Police and Crime Commissioner, the Chief Constable, and the element of public health in there has got to be questioned whether there should be more of that. So we need to have a model which can be funded, and then we can deliver this nationally. But that's the discussions we're having, and we've been charged with saying, well, what is a model that we can actually bring forward?
Okay, and what's the time scale over which we could see this if we got on with it?
So it's already started. So again, I know there's forces not mentioned today that are starting to use the experience from Checkpoint. I'm obviously looking to see how Thames Valley's project actually works. So again, some of that is happening. Again, we've done some work recently, which again I can give you an update outside the meeting in terms of which forces at the minute are starting to use similar schemes with evidence base, and therefore seeing the outcomes in terms of the benefits it brings to individuals.
Okay.
So specifically for the checkpoint scheme, we obviously had the same concerns as yourselves in relation to there's one single force going off doing an innovative project and actually what follows on through that, which is why we have actually worked in collaboration with Cambridge University on this. So we've gone through a randomised controlled trial over a 2-year period. We do have interim findings, which obviously we're more than happy to share with the committee. But in relation to making sure that we align with the Ministry of Justice proven reoffending definition, we've still got to wait another 12 months for that. But obviously interim findings show that it is currently successful. So that is what our timescales are. But in relation to that, nationally, the Ministry of Justice has also is also carrying out pilot sites with a few other forces. So the government is acknowledging that yes, they ought to evaluate the scheme as well. So that is ongoing at this moment in time as well.
To echo what the PCC said, it's extremely. It's not simply a case of rolling a scheme out, because even within Thames Valley Police, we have to speak to each local authority, to each care commissioning group, and obtain their buy-in into what we're trying to do. And if one of them were to decide that this is not in their vision or what they're trying to do, then that scheme couldn't be rolled out in that area, because we need the funding, and we need the ability for the people that we're referring drug users to be able to treat them or to be able to intervene. So I think the picture is more complex than simply adopting one approach.
So what you're really talking about is sort of pooling of departmental budgets to get away from
but across the whole country,
departmental budgetary silos,
yep,
with one group saying no, having the ability to sort of scupper the whole.
Which goes back to the issue about needs assessment, commissioning of services, and therefore making sure that the table influence the conversation.
Yeah. Okay.
In addition to that, a lot of the funding obviously happens post-court as well. So when you're looking at CRC and MPS funding, that happens all post-court, whereas what we would suggest is actually try to bring that further upstream, so that actually other forces are able to actually implement such schemes at the front end rather than waiting post-court.
Stephanie, could I just ask you to clarify what CRC funding is?
The community rehabilitation companies, so they are the statutory providers for low-level offenders,
Sorry,
and then the National Probation Service. Yes.
Medium to low.
Yes.
Thank you very much. Sorry, did you?
No, that's fine. I'm
Yeah.
That's lovely. So we come on to Diana.
So I wanted to ask you about the high rates of BAME people who appear in the arrest, prosecution and conviction statistics, and whether any of what you're talking about can start to address that and tackle it.
So we work really hard in relation to looking at the LAMI review, and in the scheme that we are running, not to require an admission of guilt in the scheme, because it's not simply ethnic minority groups, but also sections of society or different age groups that either don't trust the police or don't want to engage with the police. And actually the point or the raison d'etre of the scheme is to intervene and to help people. So the admission of guilt doesn't necessarily have bearing on that. But I think these are the pluses and the minuses of different schemes. That have to be considered before a decision is made which scheme you would like to roll out on a national basis.
I think it'd be fair to say the David Lammy report does highlight some gaps. I think there's not a consistent input in terms of looking how the criminal justice system impacts monitoring in terms of how it impacts on the BAME community. And I think we need to do more to actually capture that evidence in the way that's being looked at now as a challenge from the David Lammy report. And it's fair to say that I don't think that this is very well established, and we need to do something in policing and the criminal justice system as a whole to capture that evidence, and then to see how we make sure we sort of stop any inequalities in terms of access to interventions such as the schemes that we've got here, and access to justice. So I think there's more work to be done in this area, having looked at it across the whole of the country at the moment.
Okay, anybody else? No?
BCCs, obviously, again, not understanding, and again, the important bit here is not about generalisation. This is about understanding impact on local community. And when I say local community, it's actually our local community. What do we mean by that? What's the issues around it? And actually how the police service, making sure we're not disproportionate in terms of our response to this. Again, the schemes that are taking place here is about that early intervention. It's about not criminalising unless we have to criminalise, but importantly making sure that we stop vulnerability and reduce potentially offending in the future.
Okay, and then could I move on to if we're looking towards using a public health or harm reduction approach around drug abuse, I think a number of people would be very concerned then. What does that mean in terms of serious organised crime, county lines, and the child criminal exploitation as well. So I think it's about how would that be dealt with? How would that be approached? I guess starting with the police.
Yeah, so to make it very clear, this is not about just saying we're going soft on crime. This is not that. I make it very clear. This is about being smart, evidence-based, how we do it. So clearly in terms of serious and organised crime, we will continue with all the powers that we have got, with the law enforcement services, including other local authorities. We'll do everything we can to address the harm that those individuals, them groups, obviously creating communities. So that is around enforcement. The issue we've said, as I said, hopefully was picked up earlier on, until we stop some of the demand though, and are addressing individual need, straight away the supply will keep coming. So you still take a public health response, particularly around individual need and use, and obviously that can involve families, which links to you about domestic abuse. But the important bit for the police service is by reducing that demand through a public health response, the police service's powers can be focused on towards the things that actually addresses those that are creating the greatest harm, and that's those through serious and organised crime. That would be the messages and the message we continue to give.
Okay.
Well, we all know 90% of all serious organised criminality is drug related in one way or the other. Why is that? Because there's commercial benefit for serious organised criminal groups.
And because of prohibition.
Sorry?
And because of prohibition.
Yeah, I mean, the example is with alcohol in America, when with prohibition, criminals took the opportunity to make commercial advantage. So that continues on the basis that there is demand, which is not met by other means. That leads us into all sorts of things about what else can we do to tackle this issue. In terms of serious organised criminality, they target vulnerable groups, so we do need to work on tackling and bringing down serious organised crime groups. 90% of the time spent by police forces is on that. However, as soon as they take one organised group down, somebody else fills that vacuum. So that's why, and there are concerns with county lines, modern day slavery and trafficking in terms of, and the drug element within that. So there's a whole lot of things that it feeds that industry. So that's where the question is, how do we try to tackle this in a different way? Because just enforcement is not stopping the problem, stopping the demand, and stopping serious organised criminals using the commercial benefits of drug supply to take advantage of vulnerable people.
I think that's an important message that needs to be got across, because if people think that this is in any way going to mean that those who are exploiting people are going to have an easier ride, then that isn't going to go down well with the public. I think the public need to be reassured that the policing resources are going to go into getting these people who are the serious criminals.
We have examples from the diversion scheme that we ran. Because officers spent less time dealing with people caught for possession, we have examples of officers spending 20 minutes with an individual, referring them, and then making arrests for supply. So diversion schemes also have the opportunity to be able to shift resources, which are obviously limited, towards more serious crime.
Thank you. Were there any final points any of you wanted to make that you haven't been asked about today before you leave?
I suppose one just on behalf of the National Police Chiefs Council. Obviously, this is a really important issue for policing and communities. Again, we're really keen to work with all providers for that response to make sure we have a joined-up response. The reality is evidence base exists there that we should be looking to do, and we need to have that conversation about how we do it. The challenge, I think, comes back into in terms of resourcing and include money, because that's one of the blockers at the minute. It's not making it happen.
One point you made earlier about the statutory relationship that you have or don't have with the Health and Wellbeing Boards.
Yeah.
Is that so you would like to have that?
Well, the issue is we need to, and again, a lot of it works because we've got relationships, but there should be a statutory footing that we should have people around the table, whether that be the Police and Crime Commissioner because of commissioning, or it'd be the police service for understanding needs and demand. The piece for me is that we should have that. I have seen examples throughout the country where it's very mixed, and if it's mixed, we are not going to the table to provide information that will actually help commissioning services and therefore address the need. If we don't address the need, straight away we're getting into the police enforcement where we're having to enforce the law, which is not the solution.
You'd like to see happen, the police mode?
I think from my side, firstly, in terms of the cross-department piece of work, bringing it all together is important, but in terms of a statutory responsibility that we are at the chair around the Health and Wellbeing Board, we should have a statutory responsibility to be there as well.
Okay.
I think Police and Crime Commissioners, I mean, the majority are members of Health and Wellbeing Boards. I mean, my point would be that in order to develop a health-led approach to this issue, we do need to have better joined-up co-commissioning, and one of the areas that we need to do that is at national government level, joining up with the different departments because they all have a part to play, at a local level, and Public Health England, I think, will support this, and the Home Office most likely also support this. Our Police and Crime Commission is in terms of commissioning, not just the police, but the end crime bit where we're talking about. We can co-commission with public health departments. That would be an approach, I think, that would make progress what you are looking at the moment in terms of health-led interventions.
Stephanie said she'd like this to be given, this policy to be given to health. You talked about the cross-government work that's going on, but it's chaired by the Home Office. Would you rather it was chaired by the Department of Health or Public Health England?
That's to develop from the working group. At the moment, the recommendation of drug strategy in 2017 was that the Home Secretary chairs and coordinates all the other departments and identifies whose input is required at different levels. And it is health, it's education, it's the CLG group, departments, there's criminal justice, MOJ. Everybody has a part to play if we're going to tackle drug strategy. Health element is very important, but all the others are very important as well.
Every level that I'm of people that I meet throughout Devon and Cornwall Police Service, I'm told that it's not just about drug use, it's about wider vulnerability. Do you think that that is also an argument for having the police there on the health and wellbeing boards?
Yes. I mean, police should. I attend my health and wellbeing board, or the two in my county. I think most police and crime commissioners do. That should be there. That, in my experience, that's not where the work gets done. The work is about commissioning services around health and criminal justice, and that more we can do. So mental health, alcohol, drugs, and homelessness. If we can have better joined up commissioning of those with local leadership consistently, as opposed to based on different health groups or others deciding whether they want to do it or not, that will make much more impact.
Thank you for that, and thank you all for coming to give evidence this afternoon. Second panel, and we're really wanting to focus on users' experiences and families of users and the wider impact within the community. Could I ask you each to start by introducing yourselves and who you're representing today, starting with yourself, Emily Giles?
Yeah, I'm Emily Giles, the Policy and Communications Lead for ADFAM, which is the only national charity representing the families of those with drug and alcohol use issues. I'd like to apologise for my voice. Hopefully you can all hear me.
We can, thank you.
Yeah, I'm Kerry Hudson. I'm the service manager of the Well Communities, so we're a peer-led recovery organisation.
Thank you.
Mark Johnson, the founder and CEO of User Voice, the criminal justice charity.
Yes. Thank you. I'm just wondering, just in opening this discussion, whether each of you, starting with yourself, Kerry, and for all of you drawing on either personal experience or the experiences of people that you have been working with, could you just set the scene of the type of harms that we should be hearing about loud and clear in this committee?
Okay, so I mean, I'm happy to wear two hats here. I'm in recovery. I was a heroin addict for 16 years. I'm 11 years in abstinent recovery. I also deal with, obviously with our organisation, you know, I work with people who are trying to recover and, you know, achieve recovery. And I think some of the, you know, I was kind of discussing this on the way here, you know, it's the damage to self-esteem, you know, the damage to self-respect, it's the unresolved trauma, it's the lack of ambition, it's the stigmatisation, it's the going to places for help and getting the wrong kind of help and the wrong kind of support, which then perpetuates this feeling of uselessness and hopelessness because you can't do what people are asking you to do or what people are expecting of you. I think it's the damage to your family members, it's knowing people are fully aware of the damage that they're causing when they're in addiction, but are just incapable of stopping it. I think it's going against, you're going against your conscience, you know, you're going against what you know to be right and wrong. And I think one of the biggest things is the re-traumatisation. I'm yet to meet anyone who has tried to get help with a drug addiction or a drug problem that hasn't experienced trauma on some level. And I think the whole lifestyle causes re-traumatisation, because what it takes to actually be a drug addict, you know, the things that you go and do to get your money, you know, the crimes that you will commit, the damages to families and communities, I think they're very evident, even through your haze of the drugs that you're taking. and I think there isn't very much support for the trauma. I liked what the guy from the police said. It's about looking about what is the problem, you know, what is really the problem. It's not so much just the treatment, it's kind of going behind it, because we can keep offering the same solutions. And my experience of coming into service, I mean, I left school a heroin addict. You know, I had my first methadone script at 17 years old. Not a single person ever asked me what's happened. No. They just wanted to treat what I was presenting with, and what I was presenting with was a problem. I still believe in some cases in some forms of help. You know, that's still done. I mean, we work in hospitals, and what a lot of people do, predominantly alcoholics, will use hospitals rather than use statutory treatment services, because you can remain anonymous. And even the people who present at hospitals, I know a guy who went to hospital over 90 times to do a detox, and he was never referred into a service. So I think you can represent at hospital, and what they will deal with is the immediate thing, and then you're kind of being sent back out into the community, and and there's no support. So I think there's a lot of work to be done on integration. I think, partnership working is great, but there's a lot of work to be done to marry up, I think, all of these organisations to make it possible to work together and to have a shared respect, really, and understanding. Because if we just use the hospital as an example, I mean, I can go there with a broken arm and you'll treat my broken arm, but is anyone asking why I've got a broken arm, what's happened? Is anyone looking at the person who's going in with the injury? But what we do straight away is find out if there's any children at home. And we're not really, I think there's lots of ways that, we can be helping people, and lots of questions that we can ask, and I don't feel that the right questions are always asked.
Thank you. Mark, do you want to add to that? Tell us.
Like Kerry, I'm in recovery, 19 years. Before that, I was living on the streets of the West End. My stories are very well documented. My book, autobiography, came out in 2007. Yeah. From that, I used the money from that to set up the charity that I now founded and delivered. And it predominantly works in prison. 50 employees, 30 prisons, 2/3 of the probation CRCs we work in. And it's 90% led and delivered by people like Kerry and I. Which is the user perspective, but on a scale that it offers something sort of directly for policymakers and opinion formers and stuff around the data. My own experience is that the process which I got clean, I got off the street, I went into detox, Elephant and Castle, Equinox, which is actually the only service that still exists from 19 years ago. I went from Equinox, where I couldn't, Kerry given a great example of treating the problem, but not the causes. And so I went to Equinox, and I remember doing 6 weeks stay, but I remember breaking out the window to go and get crack and heroin, because my problem was up here, as well as deal with the physical, and it's up here, and there was no sort of therapy groups then. Do you know what I mean? So I used to run off and then score and then, get in a bigger mess. Anyway, the care manager was an ex-service user, and he worked for Turning Point, and they were doing community action work, which they don't do now. So that job's gone. And he took a risk with me, knowing I couldn't get clean because I was a chaotic intravenous crack and heroin user. And he said, you need to be more than a train ride away. So he relocated me. So form of confinement, relocation, and longevity of support are key to a person's journey. You know what I mean? So I went to this treatment centre, one of the oldest ones in Bognor Regis. The only things you can do there is die of old age or get clean. And I went there, and this guy stayed with me for another 12 months. So I had 12 months residential treatment, my feet never coming back into society for 12 months. The first 3 months I couldn't walk, and so it was about physical repair and sleeping and all this sort of stuff. And then it was about having all these, in a room quite similar to this, with not as grand as this, but the circle of chairs with peers, and I had every deluded belief I had about myself peeled away. Yeah, and it was safe to unravel and be rebuilt again in this process of drug treatment. It's gone. It's closed. The second one I went to is in Bournemouth, closed. The third one I went to in Weymouth, closed. And in place, it's got this veneer of a treatment provision, which is a day programme or information, advice and guidance to people that are at the end of the road, that are chronically addicted and that need to be away from society in order to heal, recover and get well. Some of the problems in that back then were around the measurements, the statutory services measuring the effectiveness of residential drug treatment, and they'll measure it on a cycle of like 90 days. Well, 90 days is the highest reconviction rates for an offender and highest relapse rate for a recovering drug addict. What they fail to measure around the, we talk about evidence-based practice. It looks it doesn't look like it works, right? But when you look at the disruption that it causes in somebody's mind to know there's a solution to a drug problem, it works. Trust me, it works. And it might take 10 times. Yeah, it might take 20. But when they recover, you get people like Kerry, and your boss is there, and myself, making this incremental change with other people that were unreachable in society. And what the message is hope. Yeah? And what's happened is this over-reliance on statutory services, this skills deficit, because this big corporate machine of delivering drug services en masse, you miss the point. You miss the human point. And actually, my probably case, and I'll shut up, sorry, but is to make that direct investment to the individual and do this job really well on an individual level, and look at them long term and the contributions that they make to society once they get the addiction treated. Because I've never committed another crime. I don't know about you. No. All my crime was related to drug. And we work with, in the last 6 months, User Voice worked with 10,000 people on orders, so prison and probation. Yeah, and 75% of those have drug and drug-related issues that why they're there. 35% of we work in 15 prisons which are health-related, so for the NHS, and 35% of those people said that they didn't find. They said that drug treatment services improved, but what didn't fit their need. Yeah, didn't fit their need because of this veneer. Yeah, so you can get methadone or a script or whatever, but all of the talking therapies and stuff afterwards just not there anymore. Yeah.
There was actually a study done recently where in a year's, in a 1 year time frame of going into service and a service user working with a key worker, there was only 1.5 hours of therapeutic time given with all those appointments to actually discuss what the problems might be.
So we interviewed 200 children that are in the secure estate right now. It was a report for the NHS. It was actually around spice use. So I know that Andrew's prisons minister, when it was epidemic in prison, we've done a report called Spice the Bird Killer. We're looking at doing that number 2 in prisons and the epidemic there, but we've done one intermediate on children and spice use. And we worked with 200 children who were locked up, which is a massive sample because there's not that many kids that are locked up. 75% again said that they use cannabis. So that's from 11 to 15-year-olds. And that's the other factor here, which is like a ticking time bomb, and it goes unnoticed. While we focus on academic attainment and achievement, etc., the emotional need and the causes that you said about the broken arm, we're just missing the point. And we're not getting it until the police are catching people, and they're like the default mental health service and drug treatment service. Prisons are the default drug treatment service. Yes. The amount of times you hear prisoners say, prison saved me from myself, because it physically was the only thing left. You go for treatment, there's nothing there, But yeah, the last point that I make is MPS, so the novel psychoactive substance. I'm not sure if it's talked about in your review, but it's epidemic proportion, and it's the ticking time bomb, because it's changing the drug user. See, lots of people that stop taking spice through a mental disorder because you're predisposed to having a fit or a bout of psychosis, in which case you don't take drugs after that point. They're not presenting as problematic drug users, they're mentally ill. And so it's not being connected at all in any way. The services, we talk about chronic, crack and heroin use, substance misuse services. There's nothing, to my knowledge, that's actually fit for purpose for this, for those type of users. The trajectory of drug use, you talk about, and I think it's polarised actually around county lines and stuff. I think county lines have existed since drugs have existed. Yeah. I think it's just polarised because it sounds cool and stuff, but the evidence and stuff, what I've read, is questionable at best. But the MPS, you can buy it off the internet. So you've got places like Remotas, Cornwall and stuff, which is kids have completely got access to it. Nobody's talking about it. And children who are presented in mental health services and stuff, they're not problematic drug users. They've got psychosis and they're mentally ill. So I think that's an area that we need to look at.
Thank you for pointing that out. Emily, can I bring you in here to talk about the impact on families?
Yeah, absolutely. So I was actually quite interested while these two were both talking about how similar a lot of the impacts that we see are, but obviously they're sort of one step removed. I can rattle off, and I will, a whole list of the sort of most common impacts that we see. But the really important thing to make clear is that these are really interconnected, complex issues. It came up a lot on the last panel about sort of vulnerable individuals. These are often vulnerable families, either before and often after these issues have come up. So they're not... I'm yet to meet a family member who hasn't mentioned 80-90% of this list. So relationship difficulties, family breakdown, issues with communication, severe mental ill health, it's very stressful, creates anxiety and depression, isolation from friends and family, so this is very linked to issues of stigma that we hear. So obviously I think everyone is aware that users themselves suffer from a lot of stigma, but actually the families report the same thing. They might reach out to friends or family, and if they say that their loved one has a mental health issue, then they get empathy and support. But if they then say that they're a drug user, they get sort of shunned and stigmatised quite heavily, which is a very isolating thing to experience. A lot of financial impacts, so they get into debt, whether through trying to support their loved one with an issue or through theft, being involved in some way in the criminal justice system as a result of their loved one. Physical violence and abuse is often quite common in the family, comes along with relationship breakdowns. Lots of more day-to-day impacts like missing work on a regular basis. A lot of people take on basically informal caring responsibilities. There's one lady that pops to mind whose son is in recovery now as of recently, and says that even now, and this has been going on for years, she gets about 30 or 40 phone calls a day, each day from her son, just to, it used to be to ask for money, and now it's just to check in and have someone to talk to, trying to go about a day-to-day life and go to work while your phone is ringing every 40 times a day, and you need to answer it is a real challenge. And there are lots of physical health impacts as well, mostly related to the sort of stress and anxiety that comes with all of it.
Thank you very much. Diane?
Well, I'd like to ask about problem drug use and linking it with wider issues, so poverty, lack of educational opportunities, homelessness, employment prospects. I mean, it seems to me from what you've said already that that's probably in a lot of why people go on to use drug or alcohol. I just wondered, what would you say about how society could deal with it through some fundamental changes, particularly around, say, housing or education?
Yeah, I think obviously from what I see and what I've experienced is the poverty comes first, and I think that's the predominant factor. I mean, I live in a place, there's lots of council estates, and just in the last 5 years, a lot of the funding's been cut from those estates. There's not a lot of youth support, there's not a lot of family support, there's not a lot of what there was. The estate that I moved from a couple of years ago, there were 3 stabbings in an 8-month period, and this had just been a relatively working class council estate, but with the shifts in funding and there being literally nothing for youths to do, we're on third generation, fourth generation benefit claimants, you know, there's no aspiration, you know, the local schools are not really all that good. I think there's a real hypervigilance as well in those areas where a lot of people are living quite anxiously. And then you look at the reasons why they might take drugs, and it just becomes completely obvious, because I think getting to school is really hard. For the parents to get the kids to school is hard. I think by the time these kids get to school, the stress that they've actually experienced, maybe going on an empty stomach, some of the kids know that they're going, they look scruffy, they know that they're going and they're without, and then I think when they get to school, to stay focused, to stay concentrated, to have people actually take an interest on them when they get there, look behind behaviour. I think maybe divorce rates or separation rates that exist, you know, in these communities. I think for me, when children get to school, if a school knows that a divorce or a separation is happening in a family, I mean, that's one of the biggest childhood traumas. You know, what are they doing? You know, what are they doing? And I think there's a real responsibility, because I think it's about prevention. I think it's not about let's wait till people get to 16 and they become a problem and they become criminals or they appear to be threatening. What are we doing for the 3-year-olds that are going to nursery where we know there's quite obvious problems at home? You know, where's the provision, where's the extra support, where's the counselling, where's the holistic approach, instead of looking at, are they at this point with the reading, are they at this point with the writing, tick, it looks like we're doing our job. And I just think there needs to be more resource into eyes being open to see the effects of the way that people are living and not always through choice.
I think that's we agree with what Kerry said. The other impact is, one is that taking drugs is a personal choice. Like, you have to choose to do it. And this is where the debate's been for a time, for the ill-informed, you know what I mean? Well, you chose to do it, but actually what we do know is that addiction is a phenomenon as well. So even the brightest, academic mind on psychology still has to say, don't know. and so there's things, so I look at my own drug use, but then work with a lot of people over the years, you know, with it. And actually it's about having more informed thinking and choice. And for me, in the school stuff, because the family unit, as Kerry said, is unreliable often for nurture, love, support, you know, structure, etc. It's just broke, it's gone. And especially the internet and stuff as well, you know. And then what do? They go in schools, a state institution, which is focused on academic attainment, not on emotional intelligence and being able to talk about how you think and feel. Yeah, in a safe environment and stuff. And so, if ever it's there or not in the family home, the one place that does join children at a young age is school. And what happens with people who are predisposed to drug use? They get ostracised the first time you get separated from being abnormal. Myself included. I used heroin at 11. And that's because of the social network, you know, on the housing estate. You know, it's well documented and stuff. But often the school is made to feel different. And often with the 3 types of abuses, the sexual, mental or violence, it's not the event that does the damage, it's a feeling of isolation that comes with it. And then you get a driver for self-medication, because nobody really wants to feel shit, sorry. Yeah? So, but that's a driver to want to change how you feel. And then you go into that lifestyle, in that network, and even the people that the police are talking, playing cops and robbers with on the housing estate, so they're calling them criminals, I would say even they're vulnerable, because all they're doing is economic behaviour of going, I know somebody with a little bigger parcel than you, so I'm just going to supply my own habit to do that. There is that. And so especially young people, you know, young offenders, Aylesbury's particularly, something like 50% of the people in there have serious knife crime and violent crime stuff is attributed to drugs and alcohol. And then when you ask them there, they say, what were you doing? Well, it was self-medication was the reason that they'd done it. And so their choices are completely diminished through the chemicals that they're putting inside their body, and nobody's reaching them. Nobody's reaching them to say, what's going on. So, the police, I think they're a large part of the problem. Because they're the ones that are there and probably more funded than all of the social care services. Yeah, and I've done a documentary for Radio 4, actually, where I interviewed the street users and the police. And the police are getting really well funded to give these PCSOs and all these orders for people who literally have no choice other than to sit begging because they've lost their benefits, they've got no house, they've got anxiety and depression. They can't use the local housing services because they get bullied when they go, the daycare centres and stuff. And they're literally just constantly. And for them, society doesn't have a consequence. Because how much more can you punish somebody who sat in a shop doorway or taking such high risks with their own health with this unknown substance? How can we punish people like that? But yet we attempt to. Sorry.
Now we're going to come on to the prevention angle and Johnny's.
Yes, I just was interested to know, if you say sort of police are sort of partly to blame in this, what do they do then? What do we do?
We criminalise.
I understand why
we criminalise ill
what do we
people.
Do differently? What do we do differently? What should we be doing differently to get away from that? It kind of leads into my question, if that's all right, Chair, which is clearly these issues are hugely multifactorial across many areas of society and an individual's life and family and so on, right? So what are the things that we can really do? We can talk about money and investment into addiction, and and I'd be the first to champion that, and I'm very, it's a real source of pain for me. It's the way that's happened, particularly in some of the areas that I work in Plymouth. But what would you do differently if you were in charge, if you were the Home Secretary's special advisor at the moment on drugs?
So asking me, I'll try and answer
you
quickly.
And then Kerry and then
Kerry's story and my story are not unique.
No, I know.
So we've navigated, in 20 years I've been to over 70 funerals of people I've worked with. In 4 years of getting abstinence, I employed over 200 people that are drugs and out of prison in my first business, and I won loads of awards for it. So now I've got 50, but probably about 500 people in the last after that. What Kerry's got, and people with lived experience have got of the problem, we need to bottle it. You need to follow the story from beginning to end and invest in each of those steps through. So as I said, the journey starts with an unreliable family structure. So do we do that with the state? Do we focus schooling on actually emotional well-being other than academic achievement? Because I don't know about you, but am I middle class now? But, the kids go to school and that sort of stuff, you know what I mean? And the pressure that they're under to achieve and go through these stats, I can see the stress. Never mind if you've got predisposition to being an addict or having some emotional unmet need, there's nowhere for them to go. They're completely isolated. In which case, drugs and need to escape becomes very attractive. So it's there. The policing side of it, there's an assessment to be had. I'm not a prison abolitionist, believe it or not, because I think that, obviously, as I said, for an addict, if you commit a crime, then you pay for that by being removed from society. That's an ideal opportunity to treat someone. Ideal, and it never gets done. Because we do drug treatment services en masse in prison. It's this corporate machine of box ticking, short duration information, advice and guidance programs and stuff. We need to go back to probably 2000, that level, and have that kind of investment into residential drug treatment services, of literally having people welded to the police of referral. So in the police cells, to divert people from being charged with criminal offence if they're known to be a problematic drug user, and so on, and removing the stigma behind people exiting prison or ex-drug user. And welcoming back in, and then having the industry, which you do see, you're getting more and more of, and that is people with lived experience actually integrated within all sorts of services. They're not in the police.
So what's
They're not
what's,
in prison.
and I'll just come on to you in a sec, Kerry, if that's all right. What's a bit frustrating is that that solution, the whole sort of integration of addiction into all of these touch points where the state is going to touch you, whether it's in your family, your school, when you first go to prison, whatever it may be. For a long time, people have been saying, obviously, that relationship needs to be very close together. When you started doing this, and I read parts of your books, and in 2007, when you had that event at Clarence House, and John Reed came to it, and things like that.
Good memory.
Okay, so when you meet these people, and where's the disconnect? Right, where's the disconnect between saying to the Home Secretary at the time, "This is what needs to happen," and then it doesn't happen in. I mean, you've done a lot of work. I think I know where it is. Local authority funding and things like that. Okay, but what's not getting through from your message, do you think, and why is it not getting through?
For me, it's being led by the end user perspective. So,
what do you mean?
Okay, so the person, the patient, or the offender, or whatever, is looking at the world from that perspective and not the siloed approach that the state have got. But if we put them at the front of it, you would start to see this journey. Yeah. So I call them the do's, the don'ts, and the haves. Yeah. So the do engage, the don't engage, and the have engage, and all of those people can offer a 360-degree view of the problem or the solution. Funny enough. Yeah. So there's a piece of work. It's called Reconnect with the NHS around people returning to society from prison, and it's just started. There's a second meeting there. But that was real front and centre of the whole thing around putting that person journey at the front, follow the journey, not the state institutions, because that's where we miss it. One thing I will add is where policy exacerbates this problem or actually creates it.
In what way?
Best to get, if I'll give you an example.
Yeah, go on.
So mandatory drug testing in prison is introduced in 2010. I'm sorry if I upset you, Andrew, but it was introduced in 2010. Right? So drugs will not exist in our prison. We're going to test for them. Cannabis is a drug of choice in prison. There was an immediate spike in heroin use. There's a belligerent denial that intravenous drug use exists in prison. So possibly, nobody knows because there's no reports on it. I do know the word on the wings though, and that is spiking bloodborne illness transition through people sharing needles. Because heroin stays in your system 2 days, right, in prison. So you could take on a Friday and it's out your system by the Monday. So by this policy, you've created an escalation in somebody taking high-risk choice. Point 2, MPS and the rise of it. We can get days and punitive, you get trapped punitively if you get caught with heroin, not treated, right? So if you get caught, so you don't want to get caught. So somebody comes in with this unknown substance that there's no testing parameter that's fit for purpose, it gets through MDTs. So you start taking this stuff from China that's in liquid form, sprayed on something that looks like weed, it's not. You have a one inhalation and you can go psychosis for the next 2 years. And it's taken over the prison. And all that is through the MDTs. And that's what's literally created this funnel of people taking higher risk with their health. So if we relax and this is one of somebody quite senior in HMPPS that asked, what's the answer? And I said, you're not going to want to know it. I said, what is it? And I said, stop MDTs. Well, that's not going to happen. Well, your drug use is not going to happen. And then the second part of that is the prisons have gone smoke-free, which in a real middle-class way, sorry to be politically incorrect, is a good thing. And I actually agree it's a good thing because smoking is bad for your health and stuff. However, when you look at the cohort of people entering our prisons with chronic heroin and crack use, etc., that are not getting treated, and then we come out, the state comes over and says, by the way, you're stopping smoking as well, but we'll provide cessation programs, but you can't get them for 2 weeks, in which time you've gone cold turkey off the fags, not had your drug and alcohol treated, but you just don't smoke in prison. And you've got a situation now where tobacco is more costly than spice and heroin. It's mad, and that's all policy. And if you put the service user at the front of that, or the prisoner, and however palatable that is politically around being seen to be pandering to offender needs or drug addicts' needs in the press, if you put that user experience at the foot and you've done a robust consultation before implementing policy, we might see something a bit different. Yeah? Because we need to analyse the people at the sharp end if we want a real solution to this problem.
Okay, thank you. Kelly, so we've talked about the sort of broader solutions. What would you add to that? In terms of particularly around prevention?
I think it's about healthy communities. I think, the one thing that we focus on is kind of trying to establish healthy communities that are full of all the support that people would need, and for us to have access to that support and know the roles of these different organisations. So I think one of the things that we do particularly well is we would just take just an example of one person who would enter our service and look at all the organisations that they would likely need that are going to be involved in their recovery, and do our level best to build up relationships with them, because I think quite often what's missing between statutory and third sector is that relationship, is a healthy respect. I also think the one thing that we believe in as an organisation is you don't need to go 100, 200 miles away to a rehab. I mean, I never got offered that. That was a privilege for people who had money. When I was in treatment service, it wasn't for everybody. So I got clean in my own community. And I really believe in people being able to stick around their own community, because it's either you go away or people died. You never really knew, did anybody ever recover? And I think to know that there is some supported housing, that there is a day hub facility, that there is sufficient mental health support, because what happens is when people stop taking drugs, essentially what you're doing is you're lifting the lid on a lot of the trauma, the mental health problems that exist underneath. And I don't think services can run without that mental health provision alongside it. I mean, there are lots of drug treatment programmes which are very effective in stopping people from using drugs in the short term, but what they don't do is offer a long-term solution. The long-term solutions kind of reside in, resolving the trauma. So I think I also think it needs to be localised as well. I mean, we're very active in several different communities across different counties, and the drug problems that you might find in somewhere like Fleetwood are completely different to what you might find in Barrow, to what you might find in Lancaster. So I don't think it's a one-size-fits-all. I think it's about an assessment of that community. I think it's about an assessment of need, and I think it's important to have those people with lived experience. I mean, what I find is, I still run into people that I used to use heroin with, and what have you done? How have you managed this? Wow, what's happened? And I think to see living, breathing examples, and to also have people who can speak to you in a way where you just understand. We're never trying to fix anybody, and we understand it's a relapsing condition, addiction, alcoholism, you are going to relapse, and that's okay, but you're not shoehorned out of a service. It's not right, our time's up, we're done. We create communities, so you're always a part of that community. So whether you relapse, whether you take a dip in your mental health, perhaps if you move somewhere else, you can always come back to it. So I just think it's about resourcing communities effectively.
So two sort of quite really in-depth answers there. If you could be concise, why do you think the UK currently has its highest ever levels of drug-related deaths?
Wow.
Briefly.
Briefly, why does it? I think, there's a lot of polydrug use. I think recently I got to hear about one coroner's report where there were 15 drugs in someone's system, 13 of those were prescribed. I think there could be irresponsible prescribing. I know pregabalin, that's been mentioned a lot in drug-related deaths. This is like the latest in pain, people, experiencing pain. I think we've got an ageing heroin population. We're getting people now, heroin addicts, 50 years old, kind of in a sense, casualties of harm reduction, where they've just been plied with methadone, no real vision of what recovery is, on that you can do better, optimally dosed. What you find is a lot of people don't want to be optimally dosed. Nobody wants 120 ml of methadone. You look like you belong in Madame Tussauds. You can't think, you can't speak, you can't function. A lot of people, they just want about 30 mils, then they can go about their lives. A lot of heroin addicts work.
So why are they prescribed like that?
Because it's safe, because it's harm reduction, because then they won't use on top.
And providers could call it treatment.
Yeah.
Okay.
Yeah.
When we say we're being in
Yeah.
treatment, that's what treatment is.
Yeah,
It's
that's
not.
okay.
But then the funny thing is if you speak to anyone who's been on a methadone for 25 years, they'll say, I've never been to treatment. They don't even know that they're in treatment. So the messages between treatment provider and service user. So I just think there's a lot of
reasons. Right, Emily, why do you think drug deaths are at the highest they've ever been?
To be honest, it's not a question that we have an answer to. We're focused on the family side of this.
Okay, and what about you, Mark?
I think the economic climate is a massive factor, and the need that drives people to want to get off their head, and also taking a higher risk for themselves.
So can you expand on that a little bit? The economic climate.
Well, basically the removal of so many people
of a safety net,
and creating more poverty than's ever been seen before. And I don't know how many of you guys actually, frequent some of the places where you actually live, town centres, certain estates, etc. It's visibly different. Like homelessness is probably getting on par to when I actually got off the streets. Westminster, you're literally stepping over bodies, like half-dead bodies all the time. But that's kind of, we see that daily now, and so do the public as well. And so people who experience poverty have more of a driver to want to get off their head. And that's what Kerry just talked about with driving their drug use and stuff, which is more predisposed. But also health as well, wider health. Yeah. OPD with older crack and heroin users, people don't last very long.
Yeah.
When we talk about, because we obviously work with user voice and in prison stuff, we talk about offenders being vulnerable. You know what I mean? And it's like not palatable at all. But my definition of vulnerable are people sort of more predisposed to die at their psychological illness and their lack of awareness around their health and their unhealthy choices and stuff. That group is prime target for that.
Okay.
Could I just mention one thing around families? So we've done 2 reports, one for the previous prisons minister, which is 10 priority prisons project. I don't know if anybody heard that. It's under embargo for Ministry of Justice. And then the recent one, which is out in 6 weeks, is the impact of smoke-free prisons. It's quite a substantial sort of report. And then the previous one before that was with spice use, etc. And all of them indicate the impact on the family. So the thing that we don't acknowledge is the escalation in violence, death and bullying amongst this group as well, where the criminal fraternity will get involved in this. And in prison particularly, that impacts on the family more than anybody else. So I'm talking phone calls through where people owe extortionate amounts of money, and the pressures, the phone call's gone saying your son's going to get shivved, like if you don't send regular payment and stuff. And it pushes the vulnerable group even further, but the pressure on the family, I call them the unseen victim of all of this, because we see victims as people have crime perpetrated against them, not the relationships of the relatives of the perpetrator, and that needs to kind of be probably put in there as well.
Okay, thanks, Mark. Thank you.
Andrew.
Yes, Mark, can I take you back to something you said about your own journey? And if I understood you correctly, you were saying it was the fact you were taken to residential rehab, sort of out of the area where you'd been involved in drug use that had been quite critical. Is that a correct understanding of what you said?
Yeah, absolutely, yeah. 100%. Removal, I mean, Kerry's experience is a little bit different. And there's no, it's this thing of like, well, I experienced poverty and I never took drug use. It's about the person's kind of moral faculties or, emotional and mental abilities and that sort of stuff. For me, I was living in a doorway and I'd reach the end of the road. I would inject myself probably 10, 15 times a day with a snowball, cracking heroin together. And I think that any drug addict would say that's probably the end of the road with drug use. You can't get higher or, change. So, and for me, I had to be removed from society. I had to go somewhere that literally could care physically. I remember having the socks peeled away off my feet, the first visit to the nurse. and then the physical stuff is done pretty quickly. I think I put 4 stone on in 6 weeks.
So,
and then all of the recovery started in a room which, if you left, you couldn't go back. And so that kept you there.
Just interested a little bit on the policy towards residential rehabilitation, because this seems to have gone in and out of fashion a bit. I know, I think people like Ian Duncan Smith and Oliver Letwin were very keen on it at one stage. So has it faded away just because it's more expensive and budgets are under pressure? Or, I mean, are there other people who disagree with it as a form of treatment? Or, I mean, what's your analysis as to why there's so many fewer residential options there?
The whole area is so politically charged, and that's even people in recovery, the abstinence versus the harm reduction or the controlled drug use. It's so politically charged that when you just ask this group of people how they've done it, Kerry's story very differs from mine. But I think economically, there are more expensive and fewer people getting through. And then also the measuring, I'd completely question the measuring used that shows that it's actually ineffective and day programmes are better. I think we need to have a closer look at that.
Right.
Westminster Council paid £20,000 for my drug treatment. I'm so grateful. My first tax bill was £50,000 after recovery. Yeah. There's an investment there. There's an investment case to be had. I've employed hundreds of people like me. There's a real investment case to say, work with that one, put a real quality focus with real professionals who understand the complete nature of addiction, and then let's start to build it around
I get the cost pressures, and you know, it's sort of not a secret the budgets have been under pressure because tax income always, struggles to meet sort of demand for public services. But I'm just interested that you said that this is a sort of politically fought over area. I mean, you're just speaking as an ex-user, and this worked really well for you. So I guess you're a bit mystified as to why this is a matter of sort of political debate. I mean, it was just something that worked for you. Kerry said you've got 2 hats on. So I run an organisation that's worked with 10,000 offenders in the last 6 months. Yeah, so I've had 20 years of working hand-to-hand combat with these really deluded, very ill people. Yeah, and I've watched and I've worked with and I've designed interventions with people that are getting through. And for me, the cherry on the cake is abstinence. Yeah, right. Because if you take drugs to change how you feel, I would say that the best version of a human being is one that can change how they feel in a very healthy way without the need for chemicals, right? But the political driver with this, sometimes it might be commercial. It's cheaper to whack people over the head with some methadone than it is to invest. And then the skills deficit involved. So if we get a company, you can deliver drug services across 10 prisons or even 2 prisons, where are you going to get those people from? How are you going to employ them? And how are you going to train them in the complex nature of drug addiction? So there's a resource element as well. But actually, if we dilute the quality a little bit, we could deliver this en masse. But what we lose is the quality of real experts in treating this problem of addiction. Right. Well, thank you for speaking so frankly for your own experience. It's really valuable. Just one other area from me, if I may. You were talking very powerfully at the start about dealing with the causes and not the symptoms, and I was very pleased to hear you say that. And you talked a bit about the collapse of supportive family relationships, and then were saying there wasn't the emotional support within the schools. I mean, do you think that family piece is really important? We're a bit of an outlier as a country in terms of the amount of couple separation and so on. We seem to do worse on the international stats than elsewhere within the EU. I mean, do you think that would be worth us politicians focusing on trying to strengthen some of those family relationships? Would that contribute towards a reduction in drug usage? Yes, but the understanding of family is massively different for where you go. So for me, I don't have reference points to what a healthy family is. I learn the thinking skills and the emotional stability and maturity through therapeutic intervention, because it wasn't there before.
And so if I've done a project in South Africa, and it's a project called Silence of Violence, around nurture groups in schools, where you mimic what is in a family, what does a child get in its development in the family.
So close emotional support and committed
relationship. Talking how you feel
love.
in a warm, love, supportive environment, etc. And you can actually mimic that within a sort of a school setting or a state setting. So you take the components and mimic it, and that is around not support groups because it's how they're perceived, but build it into the school, because to be honest with you, every human being could deal with that. But what it does do is it creates empathy with each other, and that's what's missing as a whole, the haves and the have-nots.
And it's the lack of empathy that drives people to take drugs, to dull the pain of not having that empathy. Would that be a reasonable summary?
No. I think the lack of empathy, one is, you're talking psychopathic behaviour, the real criminals who have the lack of empathy and stuff. With the drug addict and stuff, it's actually understanding growing up in toxic environments with, under narcissistic abuse and being repeatedly subjected to various trauma and stuff. It's kind of knocked out of you, but parts of it can be learned. And people that really understand the nature of this and how to get out of it, and arming people with the children, the facts about themselves. There's so many young offenders we work with that the social services have got documents and dossiers that much. We've got academic researchers here saying statistically 40% of this group's going to be dead, single parents, drug addicts, underachievers, and we know this, but nobody actually talks to the kids themselves to say, hey, we know that you're in this group. Do you want to go there? And then there's this outrage of it's like we harbour the dysfunction instead of arming people with the facts about themselves to say, if X, Y and Z's happen to you, you're going to be predisposed to this, and this is potentially what's on offer to you. Okay. And you need to work, and this is what I say to people, your life chances are pretty poor.
Okay.
Do you know what I mean? And that's and there's a shock there, but at least somebody can do something or start to focus about it. Yeah.
Just come back and just say that some of the witnesses to this inquiry have said that they think the abstinence approach is actually causing significant harm and possibly increasing deaths from people who've been using drugs. Is that something that you'd recognise?
No.
No.
I'd say the other way around. I think abstinence is going... So if you go... where did I use... Because I went to visit Bournemouth. Bournemouth has got the biggest, or did have, the biggest recovery community, second biggest in Europe, London being the first, but Bournemouth's like a concentrated area, and it had lots of drug rehabs that were set up in the 80s or late 70s, 80s. Now they're negligible, and the ones that do exist only take paying clients. They don't take referrals from other local authorities and stuff, and especially even if they do that, which it's actually not my awareness of, there's an issue around local connection, so people don't stay there. So the abstinence-based recovery communities are being decimated. And the most you can hope for is this thing, what they're redefining what treatment is. There's a redefinition of it, because it's easier.
Yes,
yeah?
Right.
It's easier to give methadone than it is.
If you've got the gold standard of having residential programs outside the area, that's one thing. But if you haven't got access to those, then where people are on programs where they're being taken off their methadone.
If you're doing so, here's the two particular area is prison, release them from prison, and they're doing this horrible thing, which I don't agree with, but they're doing it with retoxing. So somebody goes to prison who's a drug user, they go on substance misuse, harm reduction, so take methadone, they get clean, but before release, they ask them if they want to go back on methadone because of the spike in people that are predisposed to overdose because of being abstinent. Now, for me, drug use is a choice, and if you do the intervention well, the therapeutic intervention about being clean, if you get all of the different things involved, like somewhere to go to, the link with the community, the doctor, the GP, and the housing, then what impact does that have? So your choice is, do you have a long, slow death that Kerry talked about with long-term methadone use, and I don't have any teeth in the back of my head through long use of methadone, horrible stuff. Do you have the long, slow death of methadone use, or the risk of somebody overdosing because they take too much? That's the.
So that's your.
Yeah.
Right, Paul. You
Can I just have one point? I think it's kind of been an unfair analysis as well to kind of say around the abstinence not working, because I think what we've tried to do is introduce abstinence with a workforce that has been 25 years harm reductionists, and I think it's a completely different culture, it's a completely different mindset. It means something completely different, and I don't think the upskilling, I don't think necessarily the right people have been trying to deliver that message. And just in some of the treatment services where I am, it's the same key workers as when I was there 20 odd years ago, that have never been to mutual aid meetings, that aren't active in the communities, that have got their NHS training, so we deal with something medical, that requires a prescription, that doesn't look at the social aspects, that doesn't look at the spiritual and the emotional, and we're still using this workforce to try and introduce a concept and now say it's not worked. But the right people weren't delivering it.
What do you say to people that say that recovery can best be sustained if recovery happens within the community that people actually live in, and that to take someone with substance misuse problems into a different place to then detox them, have a series of interventions and then putting them back into that environment that they were in before is like taking somebody with cholera away to a hospital to treat them and then putting them back into the place with the contaminated water supply.
I think it's subjective, so it's down to the individual and the point in time and the people around them. So Kerry's quite articulately said that for her, she'd done it in the community. Yeah. For me, when I got clean, I didn't have a community. Like just gone, and the removal from society in that safe environment, I know for a fact, because of the Elephant and Castle, that's my own story, of literally I could not get clean in that place. So I had to go far enough away, just in the early stages, to contain it. Yeah. So I think it's about either or either. I think it's a choice. But I do think that removal and moving on does allow the extra benefit of starting again.
But then I don't think there's any harm in coming back, so I think maybe some people do need removing levels of criminality, breakdowns in relationship, they may need to be moved away. But if the community is fertilised and it's got everything that somebody might need, we don't really need to be moving people around countries, because I think in that dislocation, so essentially this is all people have ever known, we're going to move them there. How great that you can move them back. And there's lots of adequate resources in place, because moving people to a different town or a different county is not without its problems. I mean, it's all well and good when it goes well, but then you've also got the argument of releasing people into areas and creating a completely different group of drug users. And I think this is the argument, with rehabs, where they can actually, which communities they can let people back out into, because whilst it's working well, it's okay.
Ben, some questions, and then finally Paul.
Yeah. When you were talking about young people's experience, you basically gave the impression that by the time young people come into contact with the criminal justice system, it's too late. And Mark, you were a little bit, you sounded, I don't know whether you meant to get this impression, you were a little bit critical of the role of the police earlier, but we heard from the police in the evidence session before, and we've had in written evidence from them. They are very keen on, different approaches, a more health-based approach to drugs policy. They'd like to see that, but it's quite difficult for them operating within the current criminal justice framework. Do you have some sympathy with what they're trying to do and understand the constraints they're operating under?
The devil's always in the detail. So from a policy level, there's one thing. From a reality level, there's the other. And, this guy, Luke, that I interviewed, it's on Radio 4, I'm not plugging it or anything, but the documentary I've done, he'd been arrested 17 times by the police. And the police said there's nothing wrong with that. Yeah? And so the reality of it is often we have to look at the detail to get the full picture. Yeah? The illness an addiction is criminalised. And Kerry, you said it there around the amalgamating, harm reduction, long-term harm reductionists with abstinence-based people. There's that, but it's the same with the police. They don't get enough training. They do not, in mental health-wise. And I'm not saying I'm attacking police, but I'm saying there's a skills deficit there. There's a skills deficit. They are the default mechanism to pick up society's most vulnerable, and that's not right, because what happens then? You open this whole door up of stigma as well, because once you've got a criminal conviction, your life chances, and so then you go into prison, you come out, I've got a criminal conviction, nobody's going to employ me, and I might as well go back into the world that I know, and that's selling little bits of whatever, or larger bits if you find somebody that's got it.
So time and again during this inquiry, we've heard from witnesses, whoever they are and wherever they're from, that this is an area of policy where policy does not follow the evidence. Why is it? What is it about drugs and drugs policy that is so unique? Why are we so uniquely bad at establishing policy based on evidence, in your view?
Because we don't. It's the same as the law, the courts ever, is that we have the presumption that people commit crime out of the moral choice to do so, and there's no factoring in the absolute wave of mental health and psychological disorders. And we don't do it. Yeah. So if you want to have a look at it, I'm sure you've heard it. Portugal. So I sit on the drugs monitoring for Europe. Not long, but I do. Oh yeah. So I sit on the group there, and they've got the most progressive, and they've reduced the criminality and drug use as a result of it. So if we wanted that, but it's this very archaic view of people that, it's exactly the same as the law, that you come in front of the court because you've made the moral decision to do it. There's no mitigating view of mitigating circumstances behind it.
And you're a fan of the Portugal model, are you?
Yeah, yeah. And I was a real anti everything, sort of, I thought because of the fact that there's a criminal element about drug use would stop a number of children coming through. And I've turned, in 19 years, I've turned around because I've seen it and witnessed it and been quite close to it.
Fascinating, thank you.
Thank you. And then finally on to Paul.
My questions are mainly to you, Emily. I've spent many hours listening to and being educated by families and people who are not only carers but grandparent carers as well in the town where I'm an MP. I'm interested in sort of the wider picture on what role families can play in helping people with recovery, how well they're supported to do that, and what further support families might need.
Sure. So my starting point would always be that families should be supported in their own right, no matter the sort of status of the family member who's using drugs. First of all, that does have benefits for the individual if their mental health is supported and if they are given some sort of education in what's going on for their loved one, things like boundary setting and just basic awareness about the effects of these drugs, because a lot of, especially parents, will be dealing with their child's drug use with no idea really what the drug is. They've never heard of it until this happened to their child. So support for the families in their own right is really vital for the individual's recovery. The main thing in terms of the individual is that the family is well enough supported to be able to support them. But the key thing is that families are supported in their own right to deal with the plethora of issues that I talked about before. One of the biggest issues that we see is that families are only given support. Support is very inconsistently available. It used to be much more available, but it's basically due to cuts. There are lots of small local community-led services that supported families, which have been cut sort of in stages over the last 20 or so years. But where support is available, often families are only eligible for that support if their loved one is actively engaging in treatment, often within the same service at the same time, which obviously isn't always the case. Some families are still dealing with these issues even if their loved one is in recovery. Some are dealing with these issues before their loved one has got to that point where they are able to engage in recovery or in treatment. So you've got these family members who are in real crisis and have absolutely nowhere to turn to for support. And there are a huge number of different models that work. We don't sit here and advocate any one particular model. The basic argument is that services need to exist in some form in every area, which they currently don't.
Is there any evidence that money is being cut from these services?
Yeah, so I don't have any numbers for you, but I'm sure I could try and dig something out. I'd be happy to come back to you with that. Anecdotally, what we hear is that most of the long-standing services were set up, they're community-led. They were set up by a family member, often a mother. I don't have any statistics, but it most commonly seems to be a mother who's dealing with their child's substance abuse. And they've set up basically peer support groups. They meet in a town hall once a week, once a fortnight, and as many people as want to can come along and share stories and support each other. And the impact of just something as simple as that is huge, anecdotally, as I said, but I'm sure I can try and find more evidence. And the other model is services that take place within a treatment centre. Again, as I said, we don't advocate either one or the other. They all seem to be pretty effective. I can dig around to see if I can find you some better evidence.
And then finally, in terms of developing policy, in terms of being involved in the commissioning process, how effective are the people, policy makers and commissioners in involving families and involving service users when they're commissioning, designing services and policy?
Pretty poor, unfortunately. Again, it's an inconsistent picture. We work with a couple of local commissioners, and off the top of my head, I can't think which areas they're in, but again, I could follow up. We work with a couple of local commissioners who really get it and who just get that even from if you remove any moral argument, they get the investment argument that these people, need support, and it reaps its benefits back to society. But it's often been as the contracts for these things come up relatively quickly, sort of 3 to 5 year long contracts on average, and the commissioners see that there was a family support service involved in the last one, but it maybe took up a tiny amount of the budget, and they need to cut that tiny amount of the budget. So it's not seen as a central part. It's seen as like a nice to have by most commissioners, and when they have to cut something, that's something that often gets cut.
Thank you. Can I ask Kerry and Mark about service user involvement in design of services in commissioning?
Yeah, I think it's imperative. I think service user experience. I think quite often what services can think they're delivering and what's being received at the other end are two completely different things. I think services for the people who they're going to cater for should be designed by those people.
And are people involved in your experience?
They are to a degree they're involved, but I don't see that they are massively involved. I don't see the communication between commissioner and service user, and I think by the time you get to commissioner, then you might get to manager, then you might get to staff, then you might get someone who will find a service user, then you get to service user. The message that's being received from commissioner to service user is completely different. So I think if it's going to be a redesign, there needs to be some kind of levelling where the service users can sit and talk freely, with commissioners. But I also think it's about getting the right service user reps. Predominantly, it's not always the best people that kind of come forward and can speak on behalf of a population. So I think it's about communication between...
And presumably families can sometimes
be
good representatives as well, Mark.
So that's the reason I set up User Voice, is because of what Kerry just talked about and the dysfunction to it all. So if you look at commissioners, providers and end user in those three, and I'll have to give sort of talks on it, of this we listen to, and you guys, if you're the commissioner, listen to a lot of providers, and there's me and Kerry with direct experience, and I'm sure there's lots more people that are more relevant than us today, that could share that. But there's no link between, so commissioners are educated through the provider, often, organisations, and their agenda is to protect their market interest before any delivery. Nobody ever admits that they've failed in delivering a service. Everybody's been really successful. The three biggest housing charities, for instance, won't mention them, had something like a 40% increase over the last 10 years of their profit. Yeah, you see the degradation of services that are offered or the rise in street homelessness and stuff. So we need a mechanism to get the end user insight into commissioner that, as I said before, that drives all everything. It should be driving policy, etc.
So
and there should be robust consultation. So how we do it is set up democratically elected councils of prisoners. So we do, I'm not sure if I think you did visit them, Andrew, and you were the prison minister. So we got them in 30. And then so you do this wide participation. The community self-selects their own representation. Democracy is the key, but you know the dirty word democracy is the key, and that is they're issue-based, not personality-based, and they've got a term that they sit, and then they do the engagement again, and then they sit with the commissioners and then co-design together. So it gets rid of this idea, and we see it all the time. Kevin just talked about it, of you're politically motivated to want to sit at the table, or sometimes the commission is incredibly powerful with money. And so everybody gravitates with every agenda known to sit around that commissioner. To some regards, I mean, I work national level, you know, there's a little bubble that's, you know, from my world of MOJ and probation, of services that just sit around the bubble of the commissioners, and actually it's questionable whether they're actually doing anything.
Can I ask on a very practical level, local authorities commission services.
Yeah.
Does User Voice know when all the contracts are coming up for end, when what started to happen is so in 15 prisons in the south we run a health council that's a hybrid of the main one, and what's happened there, we do in those 15, I think, quote me, in the last 2 years we've done 7 procurements of services. So sometimes these are like £20 million health provider contracts. And what we've managed to negotiate is service users, i.e. the prisoners, get 10% of the procurement score, which is equal to like finance. Yeah. And then so in 2 of those 7, the prisoners have been the kingmakers, and it's that model that we really need to replicate wider at that level where the money's going. I think that's a really good practical example of when somebody is doing the specification,
yes,
and when they are setting the criteria by which they will award a contract,
yes,
they're giving 10% of those points, those scores, are awarded by service users, and therefore they have power.
Yeah. The other point of that. So one is the state has got inspections. I think is there 9 or something? I can't remember. I've met with one yesterday, the new probation one. So there's 9 inspectorates, and often they have this sort of, they go into a service, inspect and write a report of what's failing, what the recommendations are, and often it's out of date before it's actually being released. And so everybody gets frustrated. So the provider going, we've implemented all of these changes before. If you had the model of the democratically elected participation model, service providers should be sat at the table every month at management meetings about saying what's not on offer, what's not being done, and literally co-producing those solutions, which it changes the model of which the state holds its inspections. It should be done regularly as a service improvement, not a kind of a cost.
Not in a pejorative way.
Yeah.
Okay, thank you.
Okay.
Well, thank you. It's really helpful. Thank you very much for coming this afternoon.
Thanks.